All right, we are recording live for the cardiology review portion of your National Registry prep. So no jokes, no crude comments, just whisper them to me. I'll giggle silently and we'll have us a good time. Grab that door for me, make sure we don't have any unwelcome visitors. So I do want you to ask questions. I do want you to be involved. The more discussion we have, the more we can, highlight areas here. This by no means is going to be comprehensive, but I do have the man with the plan, Larry B, in the back, to answer any kind of questions that I can't answer, which is fine. As far as the EMT-B goes, there's not a whole lot of cardiology things you can do, but knowing the pathophysiology behind it and what's happening to your patient is vitally important. So let's go ahead and start on that now.
Okay. Before you start, let me say something.
Yes. Good classmates, good friends, good neighbors. So we're back in this cardiology thing, and what is the core crux of it? You have to understand what the organ is, what it does, before we get too much further down the road with it. So that's why we want to review the cardiac anatomy we have here. Why would I need to know cardiac anatomy? You know where the heart is and where the great vessels are, because if I stab you in the chest or fail in the National Registry, you need to know what vessels are being affected there, right? You need to know the path of blood through the heart. You need to know how many chambers the heart has. So the heart itself has 4 chambers. Top ones are called atria, bottom are the ventricles. They are separated by intraatrial septums and an intraventricular septum. A septum does what? It divides. You have a nasal septum as well. Divides the left from the right. There are 3 layers of heart muscle. Endocardium being the innermost layer. Get it? It's endo. It's the innermost layer of the myocardium. Myocardium, if you break the word down, myo meaning muscle, cardium meaning heart, that's the heart muscle itself. Epicardium is the outer layer covering the heart muscle. And then pericardium is that sac that surrounds the heart muscle. So the bottom of the heart is actually called the apex. It looks like a point, does it not? It's not like the one we drew in kindergarten. The big pretty one with the big wide wings at the top. That ain't the actual heart. Remembering the mnemonic we learned a while back about the valves and their order: toilet paper, my anus. So tricuspid, pulmonic, mitral, aortic, that is the valves of the heart in order. Does everybody remember the path of blood through the heart? Let's start with Ron here. What do you got? OI. You're on the spot and we're recording. This will be etched in legend from now on. Make us proud. Blood is returned to the right side of the heart by what 3 vessels? Let's hear it. Oh, you're blanking. Savannah is not representing tonight.
Superior, inferior vena cava.
Very good. So superior vena cava is draining the blood from the top of the body, bringing it back to that right atrium. Inferior vena cava is bringing the blood from the lower half of the body, going back in that right atrium. Now, who's draining the heart muscle wall itself of blood? What do you think? Coronary sinus is. Now, a lot of these vessels are named similarly. Radial artery, radial vein, coronary artery, coronary sinus. It drains. Make sense? Yes, Josh, it makes sense. You're awesome. Thanks, buddy. All right, so we talked about the atria, we talked about the ventricles. This is more for you visual learners. I'm not going to beat a dead horse there. And this is more how the valves look. So cardiac conduction, the heart muscle itself is capable of a couple of different characteristics that are important to note. First characteristic is called automaticity. Automaticity. Break the word down. Auto meaning does it all by itself. Maticity, electricity. So it can create its own electricity. At this moment in time, you have a little Pikachu in your heart, creating electricity. Very, very cool, right? Pacemaker cells are capable of generating electricity. Also, conductivity. It can conduct that electrical current to other myocardial cells. And then contractility means that the heart muscles, contractile cells, can expand and contract and squish blood out. But also excitability are the 4 characteristics of heart muscle cells. Now, the thing to remember about this is what? Dead meat don't beat. What does that mean? A patient in a myocardial infarction who is suffering heart damage from a lack of blood flow, that tissue will die off if they don't have reperfusion therapy initiated very quickly, very soon. This is how heart failure happens, is usually an MI, and that muscle is not restored to its perfusion status, and that tissue will die. So is it going to be capable of automaticity anymore? No, those cells are dead. It's going to be capable of excitability, conductivity, contractility? No. Dead meat don't beat, it don't excite, it don't conduct, it does not contract. It is worthless. Pretty much like a glass hammer. Worthless. Screen door on a submarine. Worthless. 4.8 liter Mustangs. Worthless. Hey now. I know. Should have got the 5 liter. Worthless. So the intrinsic pacemaker of the heart is going to be the SA node. SA node is who the normal pacemaker of the heart is. It is located in the top of the atria, about this area right here. Right there. It shoots it on down to the AV node. Now the AV node is meant to hold that conduction about 0.05 of a second. Reason being is the ventricles more time to fill. Now when we talk about the ventricles filling, we talk about cardiac output as well, which would be heart rate times stroke volume. A patient with a heart rate of like 20 is not going to have a great cardiac output because they're not beating enough to meet the metabolic demands of their body. What's another thing that would affect that? Their stroke volume. Let's take the patient in obstructive shock secondary to pericardial tamponade. There's fluid in their pericardial sac causing what to happen? A decrease in contractility, so that heart can't beat and push blood out. You get what I'm saying? Have I lost anybody? Do I need to stop? So I will leave the 99 for the 1. I'll move it. John, you got it? Nailing it down? Hell yeah. Alex, you good? All right, we'll keep rolling. Keep on rolling.
Before you go on, let me add one thing.
All right.
The arteries in the heart have the ability to talk to each other. I mentioned that in one of my lectures. I didn't know what that word is. Why would the arteries in the heart talk to each other?
So just so everybody that listens to this later is able to hear, Mr. Larry is saying that he mentioned in a lecture earlier that the arteries in the heart are able to talk to each other. They're talking to each other.
So, I remember that one. Why would they talk to each other? Remember, most humans are bad about building plaque out of their heart. Once it gets to the point where it's 70, 80, 90% fluid or whatever, the other arteries will dilate. Lateral circulation around it, block it. Use that either. The word is anastomosis.
Anastomosis is the word for the creation of collateral circulation between two cardiac arteries. So when this occurs, the patients or arteries are talking to each other. They're trying to find different ways to perfuse that myocardium. A way I used to remember is I would say it differently, like anastomosis. Like Moses, part of the Red Sea, he found a way, right? So this is the heart finding a way to perfuse that myocardium. And again, I'm repeating what Ms. Larry's saying because the microphone's over here, and I'll make sure you guys at home or you guys in the class that want to watch this later, that you can't actually pick up. Because I know some of the voice phones out here, they're harder to hear in the background. So if I repeat myself, that's why.
One of the things that helps it more than you know. Thins blood, makes it easier to pump. So that's why if you've got cardiac problems. Now, they're getting to the point where they're trying to say it's not good and all this stuff or whatever, but I'll leave it at this. Some of that stuff you have to take with a grain of salt. Okay, so they're saying if you don't need it, don't take it. If you've got a history done, you know, you probably do.
I like it. No, thank you for the addition. So he's added to us about anastomoses and that collateral circulation. He's also added the value of aspirin for the EMT-B in the cardiac patient, where it has that thromboxane A2 and A3, causing the platelets not to stick together. There are some people that take an aspirin every day if they got cardiac issues to keep from having clotting issues. And as most of you know or remember, we carry aspirin for emergencies and acute coronary syndrome to prevent further clots from forming. Those clots would form where? In the coronary arteries. We have left coronary and right coronary arteries. Now they can subdivide really all over the place. So what we normally focus on in EMS is what? The right coronary. And then we would focus on the left main, which divides to the left anterior descending and the left circumflex. Right coronary perfuses who? Right side of the heart for most of the people. Left coronary does the left side of the heart. And of course, the conduction system is in there as well. And that's why sometimes when a patient's having an acute myocardial infarction or heart attack, we can see it on the EKG. However, you can Google this fact for me real quick if you want. Only about 40% of people that are having an MI actually show EKG changes at all. This is why, my dear friends, is that we cannot for sure say in the field pre-hospital that they're having an MI or not. If somebody says chest pain, treat it like chest pain. Little old ladies, diabetics, old people do not present the same way that average healthy adults present. This is why I advise you to push your medic to 12-lead air body. This is how you find a little old lady that says, well, I just don't feel good today, baby. You 12-liter, good God, there's a tombstone EKG there. It means they have a big ST elevation showing big myocardial infarction, usually very poor prognosis there for them. I've had that call many times in my life, in my career. So I advise you to 12-lead air body. Listen to everybody's lung sounds, check everybody's blood sugar, do a full body assessment on everybody. Don't skip anything. This is how you find fentanyl patches, nitro patches. This is how you find insulin pumps, septic wounds. You don't miss a beat. You don't miss a beat. Be thorough with your patients. Now, taking a look up here at this guy right here, we got the right coronary branching down, doing his thing. But we also have the left coronaries over here. This area right here, before it splits, this is the left main. When it splits, it becomes the left anterior descending, left circumflex, which circumflex, its circumference, it wraps around the back side of that left side of the heart. Now, this area right here, there's a clot that forms at the fork in the road. It's called the widowmaker. Why do you think that is? Jono?
Blocks 2 arteries.
It blocks 2 arteries at the fork in the road. Widowmaker means what? It will make your wife a widow. You did. Did. Right. DRT, dead right there. Now, stranger things have happened. I had a student call me months ago. He had a patient with a widowmaker, and the guy lived. I don't know whether by some sorcery, does divine intervention or quick cath lab response, he did live. But it was a close one. Very close. So circulation going through the body. So as we talked about, blood comes to the right side of the heart through those 3 superior, inferior, and coronary sinus, goes to the right atrium, pumps to the tricuspid, goes to the right ventricle through the pulmonic valve, then it goes to the lungs through the process of diffusion. We have what? Gas exchange occur between the pulmonary capillary bed, the alveoli, goes to the pulmonary veins, jumps it into the left atrium, blood goes to the mitral or bicuspid valve, whatever you want to call it. There's 2 names for it. Then to the left ventricle and then to the aortic valve. It is pumped out through the rest of the body. Your arteries are carrying that oxygenated blood. They further subdivide in smaller areas to become arterioles. Let's take my arm here. Everybody take a look. Artery, radial artery will carry it down here. When it gets into my hand in smaller areas, we've got the arterioles perfusing the tissue in my hand. Once this tissue is perfused, that blood will then go through the capillary beds, now that it's unoxygenated, and dump into the venous system. The venules are smaller veins. They come back, dump it into the vein, which comes back and dumps it back into the vena cava. You see how that circular motion works? And then it goes right through the thing again. I lose anybody? Everybody with me? Good job. So common causes of the chest pain. There are other causes of chest pain, but because to really know if somebody's having an MI or not, you have to do a blood test. And most services I know don't carry an ISTAT on the truck, which is an ability to check lab values on the truck. They ain't spending that kind of money on you. So what's happening? The only way to really know someone's having an MI is to go get a blood test in the ER. That's why you don't need to diagnose patients in the truck. If they say chest pain, treat them for it. Don't be sitting there, where are we putting him up last week and you know, he probably just BSing again. Man, I can tell you, the boy that cries wolf, eventually there's a wolf there. And I think earlier in the program, I shared with you the story of a man I picked up for years, a couple times a week having chest pain. And I knew he just wanted to see the nurses and get a sandwich and blah, blah, blah. But I treated him for chest pain every time. And eventually one day, that boy that cried wolf, there was a wolf at the door. And guess what? My gun was loaded and ready because I always did a 12 bleed. Aspirin ain't gonna hurt him. His blood pressure was higher than giraffe booty anyway, so I gave him some nitro too. It ain't gonna hurt him. I gave him big old IV. Took him to the ER. But this time he acted differently. My spidey sense was tingling. And by that, you'll learn it once you get on the road. You'll develop, I would say, a strange sixth sense. Your gut will tell you something. Your gut will talk to you. Usually mine just says I'm hungry, but sometimes it'll say, hey, something's going on. Get back on the clock. Focus. Something's here. Pay attention. Whatever it's saying to you. I've heard my instructor's voice in the back of my head like, hey, don't do that. They're going to die. Oh, I remember that now. So remember what we've said through this thing. But there are other causes of chest pain. Of course, coronary artery disease, aortic valve disease, mitral valve prolapse, pericarditis, idiopathic hypertrophy. There's a lot of things that can be caused that are not exactly a myocardial infarction, but can you tell them in the field? No, you cannot. Especially one, again, only about 40% of MIs have ST elevation changes or any kind of EKG changes. There's also another type of myocardial infarction called a non-STEMI. Non-STEMI, so STEMI stands for ST elevation myocardial infarction. Non-STEMI, NSTMI, same thing. But that means that there is no EKG changes. So if you're out there riding with a medic, well, his EKG is fine. He's not having a heart attack. How do you know? You got troponin labs drawn on him right now? Have you taken his blood? When that cardiac muscle becomes damaged, it will start releasing chemicals that can be read. They take seconds to do, but you don't have the capability. He needs to be in a facility with a cath lab. He needs the ability to be reperfused if necessary, either through a stent, a balloon, drilling it out, or possible cabbage. What's cabbage stand for? Glad you asked.
Isn't that where they take an artery from like your leg or something?
They take an artery from your leg. All right, so we got a big clot in this area right here. No blood flow is getting through. Cabbage stands for coronary artery bypass graft. So they'll take a vein from your leg and they'll bypass the clot, and then blood flows around it and your heart's happy again. Make sense? It really means that. Coronary artery bypass. The artery is blocked, so we're going to bypass it. Matter of fact, I wish traffic worked that well, but it don't. You drove through Atlanta lately? But this morning, it probably wasn't that bad early as you came up here.
It's like a triple bypass. It's just like
If it's a triple bypass, it's including a lot of arteries. And this is not easy peasy like cath lab stuff. A cath lab, they're going to put a little wire in your artery, either your radial or your femoral, and guide it up to your heart and do all these things. And it's invasive, but it's not like, man, coronary artery bypass graft is open heart surgery. They're going to give you a zipper from here to here and crack the chest and look in there. This is a big deal. This is much more serious. So put down the KFC, leave Subway alone, eat the occasional salad. I'm talking to myself, not you. I sure had me some KFC today, and dang, was it good. So heart failure is another thing we run into. If they have a big old MI, guess what? They could have heart failure. Left heart failure is the #1 cause of right heart failure. So remember that left heart failure is wet, right heart failure is dry. Left heart failure is wet, right heart failure is dry. What does that mean? So left heart failure comes with pulmonary edema. If the left ventricle that we drew over here is now weak, all right, it's pumping blood out. It's now weakened. And remember, dead meat don't beat. It'll flow backward back to the lungs, right? So now we have fluid in the lungs because the left ventricle ain't strong enough to pump it out. So causes could be mitral valve damage, aortic valve damage, cardiomyopathy. MI is the number one cause, though, of course. Again, dead meat don't beat. Hypertension can cause it. Why?
Chronic hypertension, if you're, like, if you have super high blood pressure and your heart is constantly trying
Thickening of the wall.
There you go.
Yeah.
Good job.
Constantly trying to push against that.
Good job, guys. So the afterload is increased by the increased hypertension without being managed. So it causes what? Left ventricular hypertrophy. And that can cause heart failure as well. What about right heart failure? Left heart failure is number one cause of that. Cor pulmonale, which is right ventricular hypertrophy that occurs. A right ventricular infarct can cause it. Tricuspid valve damage. Sometimes the valves become damaged and they have to replace them. They can either do it a pig valve, sometimes they do cadaverous, and I've even heard of mechanical valves. You heard of mechanical valves? They'll do that too. They can replace valves. Arnold Schwarzenegger had a heart valve replaced, aortic valve, not long ago. Also, pulmonary embolism can cause it. What is a PE? Blood clot in your lungs that causes a VQ mismatch, ventilation perfusion mismatch. So a VQ mismatch means this. So if I got a PE going on, that means I can breathe and ventilate fine. Air's coming in and out, but there's no blood flow to my lungs, which means it's going to change the perfusion portion of my lungs. Let's take back over here to the left side of heart failure. If I have pulmonary edema, that will affect my ability to perform gas exchange, therefore causing a VQ mismatch, ventilation perfusion mismatch. Am I with me? Mr. Bonds, have you got it nailed down? Okay. It's a bit different being in class, getting lectured, isn't it? A bit more dynamic. I admit there are tools in the toolkit that are more palpable if you're in person. It's something I do prefer. I'm sorry we didn't get to share this. There's lots of techniques like loitering that I like to use. See the pressure this one's feeling now, me standing next to him. Loitering is great. Being able to call on people directly is great. It means you're going to stay attentive. I miss it. I do. It's very pleasant. But I did just start a new paramedic class this last week, and we're all live and in person, so I'm getting back my feet wet. So other signs and symptoms of right and left heart failure. Right heart failure is JVD. Peripheral edema. They'll have edema filling their periphery. Them feet will look very puffy. So it also can have that pitting edema. What is pitting edema? You can push on their skin and leave an imprint. It stays there. It goes pitting 1, 2, 3, and 4. You ain't got to worry about actually like saying which stage it is. Say, hey, we got edema. A lot of fluid going on there. Usually it's a sign of some heart failure going on. Ascites, sacral and scrotal edema. Ew. Hey now. Orthopnea. What is orthopnea? You're thinking of orthostatic hypotension. You're thinking of orthostatic hypotension. Orthopnea is positional difficulty breathing. Just like bradypnea is breathing less than 12, or tachypnea is breathing faster than 20 times a minute. Orthopnea is positional changes and problems. A lot of problems that can be created by these heart failure patients is they cannot lay flat when they sleep. So they develop what's called paroxysmal nocturnal dyspnea. They try and lay flat, fluid on their lungs settles, they wake up gasping because they can't breathe. It exacerbates their CHF. They have to call you. And to be honest, a lot of times I've fixed them by sitting them up high in a high hours, put them on a nasal cannula and letting them oxygenate for a little while. And I didn't have to get very invasive. That's great if you don't have to be invasive.
That was one of your test questions.
Sure was. Glad you were listening. Or pretending to anyway. I like it. So left heart failure, they'll get anxiety, tachycardia, hypertension, pale, sweaty skin. There's that paroxysmal nocturnal dyspnea. Rails and crackles. It is the wet heart failure. The left side is wet. And here's the pink frothy sputum. That is a tall tale registry sign of CHF. You see that, they're showing you it's CHF every time. Now, it is a later sign in real life, but again, registry's testing your cognitive ability to recognize things. They're, one of the things they did for years was to, test you on your ability to recognize a tension in the thorax, and they would use a tracheal deviation as a way to do that. However, that's an extremely late sign for that to happen. In fact, I don't think I've ever really seen it happen in real life. It's extremely late. If you're waiting to see that, there are far, far easier signs of a tension in the thorax to notice than tracheal deviation. Matter of fact, the mechanism of injury should be your first sign that it's very possible they have it.
My girlfriend took an X-ray of a lady, and she had tracheal deviation, and she could see like air pockets in the chest cavity.
All right.
The lady was a paramedic teacher too.
That's the main area.
Statesboro.
Say,
She should have known.
you should have known I'm having tracheal deviation. That's funny. Not funny. I hope she's okay. So here's another slide on some left heart failure things. So symptoms are progressive. They have dyspnea upon exertion. What does that mean? They try and walk across the yard. They start huffing and puffing. Krispy Kreme got new flavor donut. Just here. Ooh. I hate to say it, but my dear departed grandma had bad COPD and heart failure. She lived next door to me. I had to go see her, right? But she couldn't make it across the yard to see me, which is fine. I was a teenager, I'd usually eat 2 dinners. One at my house, one at Granny's. But she never stopped smoking. Matter of fact, I don't have a memory of her with her out having that long Virginia Slim in her mouth, 2-foot long cigarette. So we learned what paroxysmal nocturnal dyspnea is. We learned what orthopnea is, so I won't beat a dead horse there. So you've got that locked down. Right heart failure. The right ventricle is unable to sustain with preload and backs up into peripheral venous system. So what does that mean? We talked about it, Alex. These 3 structures bring blood back to the heart, right? So superior, inferior, coronary sinus, they're bringing blood back to the heart after it's been unoxygenated. That right side of the heart is weak. Weak. So then what happens? It backs up back into the venous system and clogs it. That's why you could see JVD, why you could see ascites. What is ascites? Big water belly. Not like dad bod like I've got, but like water belly. It's definitely fluid filled. That's why you see the venous system down here with that peripheral edema going on. Matter of fact, I had a patient one time, he had such bad right-sided heart failure, I could press on his liver and watch his JVD stick up. I know, it was pretty bad. It's fun to play with, I'll tell you that. You ever seen that, Mr. Larry? Yep. That happens sometimes out there.
Set them up at 45-degree angle and match them in the liver.
There it is.
You're remain with the stand. Every time.
Every time. Let's talk about cardiogenic shock now. Again, this is all fluff cut out. This is just, here's the problem, here's what we do about it. That's why this is the registry killer. This is doomsday registry killer. I hope it's helping you so far. How do you feel? Good, so good review. That's what I want.
I like that it's on the
Main thing. Now, I will tell you that when it comes to your registry test, the devil's in the details. Everything matters. The devil's in the details. They will ask you the most obscure bit of information at the end of the book. Do not neglect operations, and we are going to review operations before we are done. But I'm telling you, in your study habits, do not neglect the operations section. That is one that catches people because they didn't think to focus on it. But it is about 15, 18% of your test, or maybe less, but it's a good percentage of your test. I think it's 12 to 15. I can check real quick. Let's talk about it. Let's take a look. It's actually 10 to 14%. See, I came ready. If you stay ready, you ain't got to get ready. All right, we back at it. 10 to 14% of your test is operations, and 15% of every section is pediatrics. Don't neglect the babies. I have told you, we have a weakness in EMS in peds. We don't run enough of them to be great at them. I've ran pediatric arrests. Never fun. My butthole was clenched the entire time. Yes, John, extremely. And I'll tell you, they were never fun, and even though I know PALS protocol, I even teach PALS classes. I didn't feel prepared. I didn't feel ready. I just followed the steps and was systematic. That's the best I can do, but we are not that good at it. So I advise you to be as good at it as you can be. A lot of my medics friends that I know of, especially like my program director at Atlanta Fire, she actually had a bad pediatric call. And you know what she did? She went and got a job at CHOA. They don't pay her worth a poot, but she's not there for the money. She's there for the kids, but also she's there to get the exposure, the experience. And now she has a lot more confidence when dealing with kids. She's been there for years now, for years. So cardiogenic shock. Heart has reached this point where it is now a problem and it cannot meet the metabolic demands of the body. Could have been a CHF exacerbation initially. When is it shock? Is when it is hypoperfusing the body. Shock is hypoperfusion. Hypoperfusion is shock. When the body doesn't have enough heart power to reach in organ perfusion. Blood pressure has fallen. Causes include impaired myocardial contractility. Something has decreased the contractility, that stretch and pump of the heart. Impaired ventricular emptying, like left-sided heart failure, a tension pneumo, a cardiac tamponade, or a cardiac contusion. All of those are forms of obstructive shock. Remember, it's shock when the blood pressure falls. It's just an anaphylactic reaction until when blood pressure falls. CHF exacerbation until when blood pressure falls. Patient is septic until when blood pressure falls. Now they're in septic shock. Everybody with me? Have I lost anybody? All right, stay with me. So signs and symptoms, blood pressure has fallen, usually below 80 systolic, but I think anything below 100 is something to be sit up and pay attention to. They'll have respiratory distress. Why? That blood's going back up into the chest pain. Why? It's not getting enough blood flow to itself. If I took a string and tied it around your finger, it would turn red, blue, purple, black, and die, but it would hurt during that process. That is the process of injury. Infarct is when that tissue is dying. So they will have chest pain, weakness. Why? The heart is the engine of the body. If it ain't running well, you will be weak and tired. Altered mental status. Why? There's not enough blood flowing to the brain. There has to be a good, strong pump to reach the blood to the brain. Hypotension and tachycardia. What can the EMT-B do for this? Drive faster. Faith, hope, love. Maybe faith, healing. You need to either be booking it to the hospital, or you need to have a medic partner with you and remind them that the patient needs what? A pressor. Something to tighten everything up, increase the contractility of the heart, increase the rate, and to increase the blood pressure. I find that dopamine is a nice answer for this. Now, we didn't talk about it much because you are just EMT-Bs, but it's not a bad idea to remind your medic, hey, looking like cardiogenic shock, what do you think about a pressor or something there? Maybe some O2 there, huh? Consider positive inotropes and vasopressors. Inotropes are drugs that make the heart pump harder. Vasopressors have alpha agonistic properties that constrict the arteries and increase the pressure in the system so that we can reach in organ perfusion and raise the blood pressure. Have I lost anybody? That's what needs to happen. As a V, you need to be able to at least recognize what's happening, recommend to your partner, and get to the hospital or get a paramedic to that patient. That sound good? Anything for that? Hypertensive emergencies. I can tell you now, I've never worked for some place in Georgia that treated blood pressure in the field. I've never worked for anybody that ever treated blood pressure in the field. However, ERs can treat it, and also certain states may have a protocol for this. I remember reading about the administration of like a calcium channel blocker in the event of a hypertensive crisis. So hypertensive crisis would be what? Anything greater than 180 over 120. It's not actually considered super hypertensive until it's systolics over 180 and the diastolics over 120. Systolic is the amount of pressure that the left ventricle is putting out against the arterial walls, And of course, the diastolic is that filling pressure. That's the pressure inside the patient's heart during diastole and during that time of refilling. That's when we're thinking it's a big problem. Could be an unknown cause, and it's usually could be unknown while they're having a idiopathic cause of hypertensive crisis. However, it is usually due to diet, lack of exercise, and non-compliance to their medication or sub-therapeutic levels of their medication. Let's unpack that. Sub-therapeutic levels means they're not taking enough of it. Like the doctor said, take 2, you took 1. You thought you'd get away with it. Stop prescribing yourself medications. You're not a doctor, you're not a pharmacist. Take what you were told and shut up. I have an uncle in the ER right now. I mean, I love him because he's funny, but he lived with my grandma until she died. Now my mom's got a room in the back for him. He loves drugs and he hates taking his medicine. And guess what's happened? His kidneys are in failure because he didn't control his hypertension. He didn't take his medicine. All he had to do was pop a pill every day. Over 50% of the population has hypertensive issues, and it could be hereditary. I've had it since I was 17. I had a 6-pack then. Like, well, not like now, but it's hereditary for me. He decided not to take it. So what are you going to do about it? What are you going to do for hypertensive crisis? Calm the patient, get your paramedic to start an IV, oxygen, put a patient on an EKG for your paramedic, and treat underlying causes. Treat underlying causes. Recognition of it, that it is a problem. Now, there could be other causes too. Pain can cause the blood pressure to spike up. Somebody in a lot of pain will have a higher blood pressure. It can and will happen. What about a dissecting aortic aneurysm? Dissecting aortic aneurysms. Most common aortic catastrophe, and it affects 3 times as many AAAs. So a AAA is an abdominal aortic aneurysm. So what we got? Signs and symptoms of syncope, absence or reduced pulses, unequal blood pressures for the right and left side. Remember, the aorta is what branches off of the left ventricle, comes down and forms this big old pipe through your chest and thoracic and abdominal cavity. Of course, it comes down here and splits into the femoral, right? But this big boy right here, if he starts to dissect and then bursts, what do you think the prognosis for the patient is going to be? Very good. Death, fatality, finish him. Yes, he will die. It could happen on an operating table and it still could kill your patient. Me and Larry had a known friend not too long ago, very young fella that was
38 years old.
he was 30, what?
38, I think.
I thought it was 36.
Anyway,
He was mid-30s, man, and he died of a AAA. He was a good paramedic, good flight medic, good RN, great duck hunter, kind of funny. And it got him. A AAA got him. They missed it. They thought it was back pain. Some of the signs and symptoms will be back and flank pain, high blood pressure, scapular pain, and that tearing sensation in the chest and back. See, this is done in red. Why do you think that is? Why is that red? It means registry-esque. That's a registry word. Thank you. It is registry-esque. It is a buzzword. It is a sign for you to recognize in the field and on registry that this is leading you to a AAA. Chest pain that radiates to the back that feels like they're tearing, will go with AAA. Go with AAA. Management for you will be go somewhere with emergency surgery capabilities. Taking this patient to Killendale over there in DeKalb area, or Emory DeKalb, is a death sentence. Taking them to a level 1 trauma center with thoracic surgical capabilities, that could be a saving grace. Or taking them to AMC South, that'll take them out. If you like somebody, do not take them to places like that. And you know what? I don't care if somebody from there watches this video, they can kiss my grits. They can kiss my grits. You take these people where they need to be taken the first time. I've seen medics hit the easy button through the years by choosing hospitals closer to their facility that they get off at, closer to their station so they can get off on time. That ain't what we signed up for. I don't care if you get off on time. You take that person's grandmother to the right spot to get the right treatment. Do I need to take a stroke patient to a Band-Aid split place? No, I need to take them where a stroke can be intervened at. Do I need to take a chest pain patient to a place with non-cardio intervention abilities? No. So the same thing applies to this AAA. Take them somewhere they can get seen and fixed. Angina. Angina. So it's a term for meaning pain in the chest. It's a fancy way of saying it. Fancy way of saying chest pain. So basically, demand and supply have got a problem here. So the demand for oxygen and blood flow to the heart is exceeding the supply, so the chest will hurt. You dig? So we have stable, unstable, and variant angina. I need to move this little thing out of the way. Don't get up here now. So stable angina, typically sudden onset beginning with exertion. What does that mean? I was out cutting the grass, my chest started hurting. I sat down, I felt better. All right. So because he was pushing himself a little bit, it caused his heart to have that supply and demand issue. He sat down, the issue resolved itself. No biggie, right? Usually can subside with rest or just a nitro or so, and usually can fix itself in, let's say, 20 minutes or less. Now, what about unstable? Typically sudden, may initiate even during rest. I was watching TV, eating this big box of chicken, and then my chest started hurting. It won't go away. How long has it been going on? Oh, about 10 hours. Why did you wait 10 hours to call? Because I'm stubborn and I want to die. I'm from South Georgia. That's kind of a thing that happens. They'll wait to the last minute where it's real bad. May not resolve with nitroglycerin. It can last over 20 minutes. So variants here, we're talking about anything over 20 minutes that ain't fixed itself with rest or a nitro is unstable. Anything that fixed itself with the nitro or rest, we're talking about it's stable. It fixed itself. Supply and demand issue was addressed. Variant angina, also known as Prinzmetal or spasmodic angina, usually is caused by the coronary vessel vasospasm. Coronary vessel vasospasm. So something pissed off the coronary artery and it did what? Clamped down. It clamped down. You know what I've seen mostly do it? Cocaine. Yeah, I've seen a lot of that in the city of Atlanta where they'd have chest pain and it was pretty much this, a coronary vasospasm. And it is no respecter of age or persons. So it may go away spontaneously or with medication. So for the EMT-B, what do you plan to do? You can assist them with their nitro, which has what? Vasodilatory effects, or if your service has protocols written for you to give nitro, then you can do that. Remember, you must have training and authorization to perform a skill. Training and authorization. I've trained you, but if your protocol says no, that means you don't go. Make sense? I like it.
I have a quick question.
I don't care. All right, go ahead.
It's about the last slide.
Okay.
Let's make a stupid question. I was just wondering if you could clarify the difference between the AAA and the dissecting.
I couldn't tell you in a field position. They'd have to x-ray and look at it. And, there's no way for you to know the
So
difference.
they seem pretty much.
They seem pretty much the same. I have no way in the field without diagnostic equipment to differentiate between the two. They'll both have that tearing pain in the back and the other signs and symptoms. And they have to go through more diagnostics to see. I would treat them both the same in the field. Does that help?
Yeah, I was just checking.
Not a problem.
Physically, the dissecting is that thing. It's all in the aorta versus the abdominal.
Abdominal would be in the
There you go. That clears it up, don't it? I like it. So relieve their anxiety and pain. Talk to them. If their anxiety is up, what's going to happen? Heart beats faster. It demands more what? Calm them down. Relax them. Right. It's all good. I'm on the scene. Place patient in position of comfort. Oxygen. You want oxygen in the patient. Why? I guess the thought would be what? Some of those free radicals can go past the clot and help perfuse the heart, or we can hyperoxygenate the blood. These are options. What else can we talk about? Have somebody put on a 12 lead, get your paramedic there, or transport them to an ER. Go with the faster option. While I think a paramedic would be a great idea in this situation, let's say I'm in the city of Atlanta. I'm on a double basic truck. Grady Hospital's 5 minutes away. The paramedic's 20 minutes away. Go to the hospital.
Or even if they're 5 minutes away.
Even if they're 5, there you go. But if they're close by, like a minute or two, or they're already coming because it's chest pain, or a lot of times in the city of Atlanta, Atlanta Fire has paramedics on just about every engine. Make them ride the call. You're the paramedic. Here's some drugs. Handle business, baby. That's what it's about. Get somebody to do something. So what else can we do? Oxygen. What about aspirin? What's that doing? We learned about it earlier. It's stopping the clot from getting bigger. It's not going to lyse or bust current clots, but it will stop it from getting bigger. Think of it like coating it with a little force field, and they're going to bounce off of each other. Dose for that is 324 or 4 baby aspirin. Some services with money carry the 1 big adult aspirin at 325. I don't care which. Just give them about that much of aspirin. ESO did a study in 2019. They looked at 7.5 million calls and 1,200 different services. ESO is documentation software that a lot of EMS services use. They found that patients that received aspirin earlier in acute coronary syndrome had a 23% higher chance of not dying. So what does that mean? Hello, sir, you got any allergies to aspirin? You having chest pain? Here you go, here's some aspirin. As soon as I see you, I'm throwing aspirin down your throat. Here, chew these. You got teeth? Well, gum them. But get them in that patient because it will stop it from getting worse. Again, you can't save them. You're not a cardiologist. You're not the cath lab doc. That's who they need. You can, though, buy them time. Myocardial infarctions we're continuing, also known as AMI, MI, heart attacks. Blockage of coronary arteries lead to myocardial ischemia, could occur and have sudden death. If they go into sudden death over time, it'll be a cardiac arrest. How do you manage cardiac arrest? Let's talk about it. There is a chain of survival. American Heart does studies of annotative objective data every year. One of the biggest things you can do is become a CPR instructor and affect your community. You know, American Heart has data on this. It says if there is CPR applied, bystander CPR, there's a 47% chance higher of the patient surviving. Seattle, Washington has the highest survival rate in the country, a 75% resuscitation rate. You know why? Because there's a 67% chance that a bystander will do CPR on you. That's pretty big numbers, right, bro? That's one of the first things you can do is get your CPR and start teaching free classes. Invest in your community. So for the adult, carotid pulse check, the numbers we're looking for are 100 to 120 compressions per minute. 30 to 2 is your ratio for what? Breaths to compression. That is when you do not have a airway in place. You, the EMT-B, cannot place a supraglottic or a endotracheal tube, so therefore, Baggins what you're doing. Baggins what you're doing. You're going to be John Bilbo Baggins. So, compressing a minimum of 2 inches with no interruptions of more than 10 seconds. Why are there so many numbers here? Because these numbers have been extrapolated and analyzed, and they've seen what the greatest resuscitation rates are based on what was done. This is the most up-to-date resuscitation science, and this is how you have survivability, by running this thing systematically. My last 5 arrests, I got 3 back, and I didn't touch a patient. You know why? Because I sat back as the paramedic, and I made sure that the compressions were 100, 120 compressions a minute. There were 2 inches at least in depth. The recoil was going on, that the guy wasn't overbagging them, and that I was giving drugs and doing electrotherapy in the right order for the right rhythm for the right time. Systematic. So back to this adult. Now let's get to the child. Start CPR in neonate, infant, or child if the pulse is less than 60. Start bagging them if it becomes less than 100. The shockable rhythms are V-fib and pulseless V-tac. You, the EMT-B, will not be reading these rhythms. You'll be putting them on an AED. If the AED says shock, you say, okay, let's light them up. Here's some Georgia Power, and you light them up. Pulse and breathing checks, we do 5 to 10 seconds on all patients. At least 5 seconds, no more than 10. 2-minute 5 cycles for patients. For a child, do carotid pulse checks. Compressions are the same. The ratio is the same. For a single rescuer, here's the kicker. For multiple rescuers, 15-2. 15-2. Please don't goof that up. You're compressing at least 1/3 of the patient's chest or 2 inches. All right, for the carotid infant, for the infant check, carotid or brachial pulse check. With of course compressions being the same, 30-2 single, 15-2 multiple, and compressing at least 1/3 of the chest or 1.5 inches. Neonate, same thing. I like it. Myocardial infarction. This is for you visual learners. So visually, we're seeing a guy clutching his chest. He's still smoking. We got feeling faint, nausea, cold sweat, dyspnea, left arm and shoulder, back pain. So blockage of the coronary artery, we got C. There's no blood supply going to the heart. And that black area right here is what? Tissue necrosis occurring. So I think we pretty much covered MIs pretty well. What do you think? So I think I won't beat a dead horse. Leading cause of death in MIs is lethal dysarrhythmias, though. They can't have a lethal dysarrhythmia that will kill them. Ain't much you can do about that as the EMT, but recognize that they're in cardiac arrest and start compressions immediately. Remember the atypical presentations: elderly, females, chronic hypertensive patients, and diabetics. All right, in acute coronary syndrome, the drugs of choice are aspirin and nitro for you EMT-B. Know your local protocols and what to give and how to give it. Oxygenation to achieve 94% or higher. Take them to a cath lab, please. Here's aspirin broken down for you. Inhibits platelet generation of thromboxane A2, causing an antithrombotic effect. Use it for your patients there. Side effects could be epigastric discomfort. Dose 324. Nitroglycerin, we got here, potent vasodilator. Please get a 12 lead first. Hopefully there's an IV in place first. Please make sure they're not on erectile dysfunction medication first, or you can kill them. Fatality. Dose is 0.4 up to 3 times every 3 to 5 minutes. I'll tell you, some of the dogma in the EMS is kind of crazy. And I'll give you an example that, there's a fire department nearby that washes their wheels every day at 4:00 p.m. And they've been doing it now for 100 years. You know why? Tradition. You know why they actually do it? 100 years ago, they had wooden wagon wheels that were fire department wheels, and they had to wet them once a day or they'd splinter and crack. They're still doing it today, and they don't know why. I think it's hilarious that they can't break from tradition.
100 years of tradition, unimpeded by progress.
Unimpeded by progress. You're right. The original suction protocols in EMS were written by a dentist. Guess what? There's no problem with you suctioning on the way in, but you've heard me and everybody else teach you to suction on the way out, right? That's only because the dentist said so. It doesn't do any damage to suction on the way in either. Dogma, 100 years of progress, unimpeded.
100 years of tradition, unimpeded by
There you go. 100 years of tradition, unimpeded by progress. And that concludes your coronary or cardiac review for your national registry. Of course, this is not all inclusive. There's more to it, of course, but the devil's going to be in the details. That's a good, strong overview, though. I hope it helped you. Do we have any questions before I stop the recording and we start the actual cycle prep? What do you think?
What are the signs and symptoms of an MI and a diabetic, just so I can, keep an eye on that?
Keep an eye on that. So the signs and symptoms, maybe they don't have chest pain at all. They just feel weak or faint or tired because they're not getting enough myocardial blood flow. Other symptoms could include suddenly becoming diaphoretic, syncopal episodes could occur because they're not getting enough blood flow to their brain. That's about the ones I got for you.
So those are things that could also show up if they're hypoglycemic.
Yeah.
Right? So
Yeah,
you wanna check
that's
the
why you
blood
want to be
sugar.
thorough. You want to be thorough.
Check the sugar.
Very good. Checking a sugar. Oh, sugar. Well, thanks for tuning in. I hope this helps you guys. Y'all be blessed, and we're going to now work on psychomotor. Y'all have a good one.